alcohol as alcohol use increases. Before going into further details about the alcohol and mental health, I would like to just say a few words about what is mental health. We often talk about the mental disorders. When we say what is mental health, it's not just the absence of mental disorders. Like when we say definition of health, it is not just the absence of disease. So mental health has number of components like a feeling of subjective well-being, a feeling of perceived self-efficacy, feeling of autonomy, competence, intergenerational dependence, and self-actualization of one's intellectual and emotional potential. And alcohol use affect all these components of mental health. A number of psychosocial problems, again they are not a part of mental disorders, but a disturbance of functioning of mental health are associated with use of alcohol, which would include, say, violent behavior towards family members, marital problems, separations, divorces, misbehavior of social gatherings. All of us are familiar with these kind of behavioral problems which are associated with alcohol use, and also associated with unemployment and antisocial behavior. So all these problems I am highlighting to sensitize, to especially the younger delegates and students, to sensitize them to the problems associated with alcohol. As also pointed out by previous speakers, even a level of as low as 20 to 30 milligram % of alcohol in the blood is associated with adverse performances of our body. Like this level is associated with slow motor performance and decreased thinking ability. As level increases, there is an increase in the motor and cognitive problems. And in our country, the 30 milligram % is associated with the is considered legal limit for driving. As we got 80 milligram, there is an increase in coordination, judgment error, lability of mood, further deviation in cognition, and further neurological complications occur with a further rise in the level. And a 300 plus milligram % level is associated with impairment of vital signs like heart rate, blood pressure, and may result in death at this level. So a very heavy intoxication may have the possibility of fatal consequences. Now, what are the different mental health conditions which are associated with use of alcohol? These include some behavioral issues specifically related to alcohol, which include harmful alcohol abuse, alcohol dependence syndrome, alcohol intoxication, alcohol withdrawal state, alcohol withdrawal delirium, alcohol-induced persisting amusing disorder, Wernicke-Korsakoff psychosis, persistent dementia, and then specific psychiatric conditions like psychotic disorders, mood disorders, or anxiety disorders which are associated with use of alcohol. I'll be also briefly discussing about the alcohol-associated neurocognitive dysfunction because Dr. Padma, who was to make the presentation, is not here. Now, what we call harmful alcohol abuse or harmful alcohol use. These days we don't use the word abuse. The modern classification system, they don't use the word abuse. We use the word just harmful use. Harmful use is a pattern of use which is associated with damage to health, and person is aware of this damage. So there is a difference between simple alcohol use and harmful alcohol use. So there is a damage to health which could be physical health or mental health, and person is often criticized for his behavior due to alcohol by others for alcohol-induced behavior, and there are adverse social consequences like fight or conflict with law, traffic violations. So at that stage, the use of alcohol becomes harmful use. Now, what is dependence? When the person is found that he or she has become dependent on alcohol, in this there are a cluster of symptoms which include behavioral symptoms, which include cognitive symptoms or physiological symptoms. Like person has craving and incessant desire to take alcohol. Every day evening, a person who is dependent would just walk to the wine shop or say to a bar, no one can stop him. He is a strong urge. There is a difficulty cutting down on the amount of drinking, or has difficulty in stopping his drink. Develops withdrawal symptoms whenever he or she tries to stop. I'll be discussing in more detail what are the withdrawal symptoms. There is an increasing amount. This is a physiological characteristic that there is increasing amount of alcohol is required to have the same effect. And this person starts neglecting his or her interest, responsibility. Due to time he spends on getting alcohol and he remains intoxicated under alcohol. So a lot of time he or she is spending on just under influence of alcohol or while drinking, or say time taken to procure alcohol from different places. And he persists with this use despite clear evidence of different harmful consequences, which could be physical, which could be mental or physiological. Now coming to what is alcohol intoxication. It's a simple that person has had heavy dose of alcohol, and after that, under that influence, the person is intoxicated. In this, there may be different kinds of behaviors like sexual or aggressive behavior, mood disability, impaired judgment, and then there could be neurological symptoms like slurring of speech, incoordination, unsteady gait, nystagmus, and ultimately progressing into stupor or coma. Now, whenever a person, the effect of alcohol goes off in a person who is dependent on it, the person develops withdrawal symptoms. Now, these withdrawal symptoms can be in different forms. In the form of generalized tremulousness is a very characteristic symptom, especially a person who is dependent on it. In the morning, when the person gets up, the first thing he gets tremulousness, that's also called morning shakes or tremors, and the person tries to have another drink, and after that those symptoms disappear. Classically, it appears after 6 to 8 hours of last intake, so that's how the person gets symptoms in the morning. Because he has taken a last drink in say around 10, 11 or 12, and in the morning when he or she gets up, he gets these symptoms. There could be perceptual symptoms or psychotic symptoms which appear slightly later, and seizures can also occur after 12 to 24 hours in persons who are dependent on it. And delirium, which is a classical psychotic syndrome, or classical syndrome which is seen with use of long-standing use of alcohol, occurs usually after 24 hours. So there are tremulousness, there are autonomic sympathetic hyperactivity like sweating, tachycardia, anxiety, irritability, difficulty getting sleep. There could be gastrointestinal symptoms like nausea, vomiting. The person appears alert during this condition, during the initial period of withdrawal, but may start a wriggling. It's very anxious, very tense, but appears oriented. Unless the person goes into delirium at a slightly later stage, person is may be agitated. Some of the persons, though it's not very common, it's much less common, may get withdrawal seizure. So this is a serious complication. And what happens is this often gets misdiagnosed also, because when the person gets withdrawal seizure, the person may end up in emergency, and management of epilepsy may be instituted, because history of alcohol may not be available. It's only if the history of alcohol becomes available, then person would be treated for alcohol withdrawal seizure, but by that time the person has already got a heavy dose of antiepileptics like phenytoin. In such cases, why I am emphasizing, because we have a lot of young colleagues who need to be sensitized with this thing, because we will be seeing such cases in emergency. Differential diagnosis considers whenever a person with epileptic seizures comes, you have to consider differentials of head injury, CNS infection, CNS neuroplasm, hypoglycemia, hyponatremia. Where all these conditions can lead to sudden seizure in the absence of previous history of epilepsy. And benzodiazepines are the usual treatment of choice for withdrawal seizures. It's not the anti-epileptic, it's benzodiazepines like diazepam, lorazepam. Diazepam is available in injectable form in our country. Now, delirium tremens, which I just referred to, this is a purely brief psychiatric syndrome which is associated with heavy use of alcohol, and whenever a person tries to stop it or tries to reduce drinking. And one common situation in delirium is a patient gets admitted to a medicine or surgery ward or any of the wards in a hospital, and after 24 hours, after 1 to 2 days of admission, the person develops delirium. Reason being, the hospital person has not been able to get alcohol, and that time the person develops delirium. And the problem of alcohol is recognized for the first time in the hospital at the time. This is a life-threatening situation with a mortality of 20% if it remains untreated, and which remains even at 5% even in the treated population. So this is such a serious condition associated with the long-term use of alcohol. Generally seen after 5 to 15 years of heavy drinking. And there is a classical triad of symptoms, which is clouding of consciousness and confusion. Person may show visual hallucinations after seeing imaginary figures, and sometimes may try to attack the person whom he or she is seeing, and may injure himself, or may sometimes fall from the bed, or may try to jump from the window. So that way the person needs very careful monitoring. And there are marked tremors, associated delusions, agitation, insomnia, and the reversal of the sleep-wake cycle. Often the symptoms become more pronounced in the evening as the darkness starts, the symptoms become more pronounced. The next is the Wernicke syndrome, Wernicke encephalopathy or alcoholic encephalopathy. This is a neurological condition which is seen with use of alcohol, and occurs again when the person stops alcohol, becomes abstinent in the initial few days, and it's characterized by the neuropathological lesions. So the cause lies in the brain, in the paraventricular areas, memory bodies, thalamus, hypothalamus. These are the different areas involved in with the encephalopathy. And the clinical presentation consists of ataxia, incoordinated gait, vestibular dysfunction, confusion, and there are classical ocular abnormalities. Classical abnormalities in eye examination in the form of nystagmus, lateral orbital palsy, gaze palsy, sluggish reaction to light. So, and these are signs which can be easily identified. They are not difficult to identify unless the person is not careful in examining. Then there is the alcohol-induced persisting amnesic disorder. This is after the person is recovering from Wernicke encephalopathy, especially if the person is not aggressively treated for during the withdrawal state and for Wernicke encephalopathy, the person may going to go on to develop amnesic syndrome, which is characterized by there is a disturbance in short-term memory, especially the recent memory, in which the learning of new material is affected. There is a disturbance of time span. Person often indulges in conservations, often would come with wonderful stories to fill up the time gaps, because person is not able to remember. So this kind of rearranging of chronology is seen in the patients who suffer from Korsakoff syndrome. And there is the immediate memory is intact. A person, if you tell something at a time immediately, a person would be able to recall, but the events of say 1 or 2 days prior to that, person may not be able to recall. And consciousness is intact in this thing. The another neurological syndrome or the neurocognitive disorder, which is associated with use of alcohol, is persisting dementia. Now, this is a condition which has some controversies whether it's alcohol is causing the condition, or alcohol is leading to dementia, or is the adverse effect of alcohol on different body organs. Like alcoholism is often associated with frequent head injuries, poor nutrition, and malfunctioning of different other organs like liver or renal system or pancreas. Whether this is secondary to the adverse effects of alcohol on other body systems, or is directly related to use of alcohol. There is a cortical atrophy, the sign of dementia, and large ventricles. Now, blackout is another common neurocognitive disturbance which is seen with chronic use of alcohol, in which the person is unable to remember the events which happened when the person was intoxicated, usually seen in the person with heavy drinking. Apparently, the person was awake when he had taken those heavy dose of alcohol, but is not able to remember the events of that period. So that's called blackout. Nearly 40% of drinkers suffer blackout at some time. Then there is alcohol-induced psychotic disorder. In this person may present with delusions, hallucinations, the classical symptoms of psychosis, or if the hallucinations are more common. But sensorium is clear, and the person is fully conscious. So that's a distinguishing point from delirium tremens. And this may happen, may start during intoxication or during the withdrawal phase. Same way, use of alcohol is associated with depression, with mania, bipolar disorder, and we make a diagnosis of alcohol-induced mood disorders only when the symptoms are directly attributable to use of alcohol, like the onset is during intoxication or withdrawal. As such, there is a high comorbidity of depression and mood disorders with use of alcohol, but there are the coexisting conditions, and we call it alcohol-induced when it's seen during intoxication or during withdrawal phase. Same way with alcohol-induced anxiety disorders, things like panic, generalized anxiety disorder, obsession. Now, how do we manage alcohol use disorders in clinical practice? Now, treatment of alcohol use does not require any specialization in most of the cases. Only in the complicated cases it would require specific skills. But the initiation of alcohol use treatment can definitely be done at the primary care level. Any doctor can start the treatment of alcohol use disorders. So that's why I'm putting so much of emphasis, and in all the subsequent lectures by Dr. P.D. Garg, he would be discussing about the primary, secondary, and tertiary management of alcohol use in different settings. So there are three steps in treatment of alcohol use disorders. One is intervention, detoxification, and rehabilitation. Now, every patient who is using alcohol, any person who is using alcohol is always in a phase of denial. Person would never accept that he or she has got, of course in our Indian situation is mostly he, that he has got a alcohol use problem. So one of the most important thing is to identify the problem and motivate the patient. Often this problem is hidden, or problem remains because person is in phase of denial, person never gives a history of alcohol. So as a doctor we have responsibility to early identification, and we should always take history of alcohol use on every visit. Whenever a person comes for any problem, we can ask one person, and that helps in sensitizing the person to use of alcohol. And we should always emphasize on adverse consequences of alcohol. This is not one or two visits. If it's done on every visit, this will help in creating sensitization and motivate the person to come for treatment, to accept the problem and to come for treatment. We try to bring about the presenting problem. If a person has come for a sleep disturbance or sexual issues, depression, or say liver problem or some other medical problem. So we try to emphasize that this problem has got a relationship with use of alcohol. So that will help in motivating the person to seek treatment and to accept the problem. And one of course should never be critical, should be non-judgmental, but one needs to be persistent. So I'm putting so much emphasis on this because this is very important and with our young colleagues. And as I said, single intervention is rarely sufficient. Now, then comes the next step, that is the detoxification, because person has been using alcohol for a long period, and if person stops it suddenly, that's going to have serious adverse consequences, which could be delirium, which is a very serious condition and with a high potential of fatality. Then encephalopathy, which could also be irreversible. So that's why we need to go for a systematic treatment and systematic detoxification. So address cessation is never recommended. Now, most patients can be managed on outpatient basis. Purpose is to reduce subjective and objective discomfort to prevent complications. But before that, we have to go for assessment, which includes history of previous episodes of withdrawal, physical examination, routine investigation, kidney function, liver function, time of most recent drink, competent use of other substances, severity of earlier record if the person had, and coexisting medical or psychiatric disorders. Generally, the benzodiazepines, chlordiazepoxide, which is a usually we use long-acting benzodiazepines. In India, we have chlordiazepoxide, which is a standard treatment, and diazepam. These two drugs are usually used, and the detoxification phase does not last long. It's over in 7 to 10 days, and we reduce the dose of drugs every day by nearly 20%. And when the liver function is compromised, there we use short-acting benzodiazepines, which are lorazepam or oxazepam. And then we also give thiamine supplementation, which is because the persons with long-standing alcohol problem often suffer thiamine deficiency. So thiamine, if a person has features of onychoencephalopathy, we give parenterally, otherwise oral thiamine can be given. Then comes the phase of rehabilitation. Now, rehabilitation, there are three components of rehabilitation. One is the continued effort to increase and maintain motivation. Seizures are very common, but alcohol dependent on alcohol use disorders, they are a medical illness. They are not only social problems, they are medical illnesses. And any medical illness can have relapses, so we need to maintain motivation. We have to help the patient to readjust to a lifestyle free of alcohol. Earlier, the person was spending a lot of time in procuring alcohol, was intoxicated, so almost his whole daily schedule was circled around alcohol. So we have to bring him back to a lifestyle which is free of alcohol. We have to improve his physical functioning, psychosocial functioning. He is to be reintegrated in the family, which has been lost over the period. We have to remind the patient about the importance of abstinence, to maintain it, to develop new support systems, new coping styles. Whenever a person offers and drinks, so we have to tell him how to refuse. So these are the things where we need to emphasize in the rehabilitation phase. Then we have some medication, other methods available to prevent relapse, which are common. There are non-pharmacological methods as well as pharmacological methods. Counseling is needed for several months. This could be once a week, twice a week, or twice a week, depending on the convenience, facilities, whether a person is able to come to the facilities, how frequently. So, and this needs to be continued for at least 6 months. This counseling could be done in an individual session, or it could be done in a group session. Focus is on day-to-day life issues to build a lifestyle free of alcohol, as I emphasized earlier also. To develop new social and recreational events, invest in the new social and recreational events, and to re-establish communication with the family and with the friends. And then we have to identify situations where risk of relapse is high and how to cope up with those situations, like a friend offers him drink, or say he's talking to a stressful phase, how to face that, how to cope with this stress without alcohol. So whenever any slips occur, they need to be dealt with support. Family needs to be educated, family should not be critical, family should be supportive. Same way, the spouse can be a great support, great help in this situation. And there we have some self-help groups like Alcoholics Anonymous, which help in maintaining relapse. Then there are some medications which are available. Now, when it comes to medications used for relapse prevention, they are given the specialist arena. They should not be used at the primary care level. They are to be used only at the specialist level. This one is called disulfiram, which is taken when a person is on disulfiram and person takes alcohol, there could be adverse reactions. So it's a deterrent. Then there are anti-craving agents like naltrexone and acamprosate. So we have a range of help available for treatment of alcohol dependence. If a person develops delirium tremens, which is an emergency, person needs to be hospitalized. That's very important. Person has to be kept in a protected environment with minimal sensory stimuli. Intravenous diazepam is used 10 mg every 20 minutes till the person is sedated. Now this is again comes with a specialist arena, and person needs to be hospitalized. Can be done by a physician or by psychiatrist. Then there are alcohol-induced mental disorders like psychosis or depression or anxiety. Then we need to introduce specific treatment for the conditions like antipsychotics for psychosis, antidepressants for depression, or anti-anxiety medications for a person is having anxiety disorder. World Health Organization has given guidelines for management of alcohol-related disorders in primary care. In fact, I have tried to include these guidelines in my presentation. These are available freely on the net, free download. Now, coming to what is the prognosis of alcohol use disorders and alcohol and mental health. Nearly 10 to 40% of the persons who use alcohol, they enter some kind of common treatment. Good prognostic factors include absence of antisocial personality disorder, absence of other substance abuse, absence of comorbid psychiatric morbidity, general life stability like a job, presence of family support, absence of legal issues, and compliance with treatment. 1 year abstinence has been found to be associated with continued abstinence over long periods. To conclude, I would like to re-emphasize alcohol use is harmful, and harmful alcohol use and alcohol use disorders, they are medical illnesses and they need treatment. It's not a habit, it's a medical illness. And alcohol has number of adverse effects on mental health as well as physical health, and is responsible for a range of such physical and mental conditions. And every doctor needs to take active alcohol use in all patients on each visit. That will help in reducing and motivating a person for treatment. And treatment of alcohol use disorders requires high motivation, but most patients can be helped. And there is a need of alcohol policy at national level, and that's the reason this symposium, today's symposium has been organized. There's a lot of information available on this website, www.alcoholdrugindia.com. This has been developed by the National Drug Dependence Treatment Center in. Thank you.
After how much time from staining alcohol, the person will stop taking that withdrawal?
After?
How much time from staining alcohol, the person will not get the withdrawal symptoms?
See, symptoms would start after 6 to 8 hours. And usually, sometimes the protected withdrawal symptoms can occur even after a month or so. But usually after repeat detoxify the patient, usually give us drugs for 7 to 10 days. So it's presumed that after that symptoms, the withdrawal symptoms won't, serious withdrawal symptoms won't occur, but some kind of craving may continue for reasonable time.
That is for 1 month.
This could be 1 month, it could be 3 months, because as a person, like a person who has been drinking for years, while he is passing through a wine shop, so he may get, because such cues which are associated with use of alcohol, that can lead to this kind of manifestations. But as the time becomes more and more, like I said, that if the person is able to stay abstinent for a year, then prognosis becomes much more favorable.